Privileged to have you join us. Immediately following today's presentation, we will have a question and answer period, so please feel free to submit your questions in the area provided in the GoToMeeting dashboard. The participant phone line will be muted for today's presentation. The materials will be emailed to you along with an audio playback shortly after the conclusion of this session. A complimentary white paper on this topic will also be emailed to you later in the week. As you exit the webinar, a brief survey will pop up, and we would greatly appreciate your feedback on this presentation as well as suggestions for future topics. Dr. Ellis McKnight will be leading today's discussion on strategic planning for hospitals and healthcare systems. Dr. Knight is the Senior Vice President and the Chief Medical Officer for Coker Group and oversees the Hospital Operations Strategic Services service line. With over 30 years in the healthcare arena, he has developed a significant experience and knowledge in this industry. He has a special interest and expertise in population health management, clinical care process design, cost accounting, and hospital physician integration. Please join me in welcoming Dr. Knight to begin the discussion on strategic planning for hospitals and healthcare systems. Dr. Knight?
Thank you, Savannah. I appreciate it. And I welcome all of you who have joined us this afternoon for this presentation. I'll tell you that having done several of these seminars now for Coker, I am especially excited about today's topic in that strategic planning, I believe, is one of the more neglected aspects of healthcare delivery in the hospitals and healthcare systems that we work with across the country at Coker Group. And I don't mean that statement to be disparaging, but simply the fact that I think the tasks at hand in terms of managing healthcare facilities, healthcare organizations in this day and age is so enormous that the opportunity to sit back and to do strategic planning and to think strategically, especially as we're going to define it and discuss it further today, is just something that most organizations don't really have the luxury of doing. So hopefully what I can accomplish today with you is some tips about how to do this, about how to approach strategic planning, and even more importantly, perhaps some areas of focus that you may want to consider as you go about this process. So let's get right to it. As Savannah said in the introduction, I would also note that there is an accompanying white paper with this presentation, and we'll be sending that out after the presentation to all of you who are participating, and I look forward to also hearing feedback from any of you, both at that time or during the closing minutes of this presentation, when we'll try to make sure that there's enough time for some Q&A session. So the agenda for today is that I want to set the stage a little bit and talk to you about the unique aspects and indispensable value of strategy setting and healthcare planning. I want to try to define, at least from this observer's point of view, what strategy really is and how you should use that term and go about that task. I want to talk about the healthcare industry in particular, and talk about the importance and often lack of true competitive differentiation across the healthcare industry by hospitals or healthcare systems. We're going to talk about a concept called trade-offs, which I think is one of the major points that I want to bring home to you today. And then, as I mentioned earlier, we're going to talk about some key strategic issues for hospitals and healthcare systems that I know for a fact many of you are dealing with, struggling with, and hopefully we can bring you some innovations and some ideas that you might find valuable to apply to those areas of your strategic approach in your particular organizations. So let's start with strategy in healthcare. You know, healthcare provision and those that manage healthcare organizations is a rather unique industry in that I think everybody would agree those at the top of healthcare organizations tend to be an amalgam of both those that come from a clinical background and those that come from more of a professional management or business background. There are many, including myself, who have tried to combine those two perspectives, but nevertheless, I think healthcare has this dynamic tension, if you will, that exists within the C-suite and elsewhere, in that our professional ties, our clinical perspectives oftentimes cloud and really affect what we do from a business strategic perspective. And unless we realize that, and unless we take what I think can be an advantage of that, I think we leave ourselves short when it comes to strategic planning in healthcare. The other thing that I think makes healthcare rather unique is the pace of change in our industry. I don't need to tell any of you who are now going through this really unprecedented period of change in the healthcare delivery system what I'm talking about. With the advent of the Affordable Care Act in 2010 and all the rollout that we've had even prior to that and since then, the changes just seem to come more and more quickly and rapidly. And even as you've seen with the recent Ebola crisis, some of the changes and some of the challenges come about seemingly out of nowhere. And there is no amount of strategic planning that can really adequately prepare us for all the potentialities that are popping up on the horizon. So healthcare is really a management challenge of monumental proportions, and trying to get your arms around strategic planning in healthcare, or even particularly for a specific organization or facility, can really, really be difficult. So what is strategy? I don't want to oversimplify things here, but I think this is a term that gets batted around a lot, and perhaps there's a lot of confusion that occurs because of that, and therefore very, very clear strategic planning and proper approach to this doesn't get done. One of the, I would say, premier thinkers with regards to especially competitive business strategy is Michael Porter at the Harvard Business School. Many of you have read Dr. Porter's works. His 5 forces model of competitive strategy is fairly famous within the business literature. And I think he's got an approach to looking at strategy that is and can be very valuable to you as healthcare managers. So what Dr. Porter says is that we must distinguish competitive differentiation from operational effectiveness. And he goes on to even more strongly say that operational effectiveness in and of itself is really not a strategy. And that as we go around and attempt to one-up each other in the healthcare industry, whether it be hospital against hospital, healthcare system against healthcare system, or even service line against service line, what we're doing there is not really a strategic approach, but more of an approach that leads to commoditization of services and pushes out what Porter calls the value frontier, which provides diminishing returns for those that get caught up in these kind of tit-for-tat competitive relationships with other healthcare providers in their communities. And that commoditization of services and that competitive effort against each other with regards to operational effectiveness really provides no relevant benefit to the individual providers who partake in that. Instead, Porter recommends what he calls strategic positioning, which he describes as a unique set of activities or approaches to service delivery that others find difficult, if not impossible, to emulate. So I'd like you to think about that for a minute and think about the many, many things that you do in your organizations today that you may consider strategic, but are really just attempts to kind of follow the herd and emulate others in the community, other healthcare providers, and not trying to set yourself up into a really unique strategic position where what you do is, as Porter says, competitively differentiate yourself from others in the field. So operational effectiveness, what are we talking about here? We're talking about things like the CMS Core Measures, which I've been involved in hospital quality improvement efforts for a long time. And I think any of you that have also been involved in saying no, that as those core measures are pursued by hospitals and healthcare systems, not that that's not a good thing, but what happens is that the gap between the top performing hospitals and the lower performing hospitals narrows, and the competitive differentiation that you are able to enjoy or achieve by pushing up your core measure scores really is elusive. That again, there's really nothing to differentiate those that score 99% compliance with CMS core measures or care practice guidelines, and those that score at 100%. And so it becomes a real kind of race to a very, very smaller and smaller ability to differentiate yourself from others. Other examples, I put down the Vinci Robot. In the organization where I used to work, we first bought one robot, then we bought another one. And with each of those activities came a lot of marketing efforts and a lot of publicity about we're the first in the market with the robot, we've got the robot, we can do things robotically that others can't. And before long, everybody had a robot. And when you look at the clinical rationale for this, there really is only a very, very, very small, if any, advantage for doing most of the things robotically in surgery that people are using this for. So it became more of a marketing effort, and a marketing effort I would contend that was not very strategic in that it really didn't differentiate yourselves from others in the neighborhood. I think we've seen that with cardiac surgery programs, with bariatric surgery programs, and even in my specialty of primary care internal medicine with patient-centered medical home network and the development of these, what may be initially unique offerings, but then again the bandwagon effect kicks in and others jump on board, and these activities don't really serve to differentiate yourself strategically from others. So what am I talking about in terms of this strategic positioning that would replace just chasing this operational effectiveness and doing what others do? I think you can look around the healthcare industry and also see some pretty good examples of those. AmSurge with their creation of a large network of ambulatory surgery centers. CVS Caremark with the development of their minute clinics and and rapid expansion into the retail medicine space. There is something out there now called the National Orthopedic and Spine Alliance. This is a consortium of providers. I believe it's the Cleveland Clinic, Ortho Carolina in Charlotte, North Carolina, CORE, which is a orthopedic practice in Phoenix, and the Rothman Institute in Philadelphia. And these groups have come together and they've packaged orthopedic total joint replacement surgery and spine surgery. They priced that out on a bundled pricing basis, and they've contracted with large employers across the country for bundled pricing on those services, and also what you might call warranties on those services, in that even complications post-operatively are covered by the procedure cost. So these are innovations that are out there, they're occurring, and they're really quite disruptive when you look at the power of somebody coming along and doing something like this. It's really quite different than most healthcare providers are doing, and really tends to set them apart from others in the industry. So let's move on now and talk about, if you're going to go down this road of competitive differentiation and try to take a strategic approach that really sets you apart from the competition, what are some of the key things that you need to do? Well, trade-offs is one of those things. And somebody said long ago, and I think it's very true, that sometimes in strategy setting, it's more important not what you're going to do, but what you're not going to do. We all know that you know, if resources weren't limited, if we could spend all the money and had all the people available that we needed to effectuate any strategy, then the gloves would be off, and we really wouldn't, the strategic planning process wouldn't be so difficult. But that's not the real world, and limited resources in all our organizations across the healthcare industry really demand that we establish trade-offs. In other words, if we're going to allocate resources to do something very unique and different, what is the trade-off for doing that? What are we not going to spend resources on? And what is going to be the return on our investment for making that trade-off? So perhaps this is best illustrated by looking at industries outside of healthcare. One of the most fun things that I like to do is to read case studies, usually from the Harvard Business Review, on specific companies and firms out there who really take this innovative, unique, strategic approach to things and have really kind of caused significant disruption within their own industry. So let's talk about Progressive Insurance. I'm sure that some of you, or a lot of you, have seen these little Progressive SUVs that drive around and seem to be kind of omnipresent on the highways. What those are actual claims adjusters for Progressive Insurance Company who react to accidents and actually go to the scene of an accident where they are willing to adjudicate a claim and, believe it or not, even cut a check on the spot for the client who's in an automobile accident and has suffered that sort of an event. Progressive did that because they realized that one of their largest costs was the length and time and financial resources involved with adjudicating claims after the fact. So once the lawyers get involved, once things start trickling through the bureaucracy of the insurance claims processing system, it gets to be a very, very expensive proposition. And so Progressive came up with this idea that they could put these fleet of SUVs out there go to the scene of an accident, settle that claim on the spot, and yes, that's an expensive way to do business, but the trade-off that they felt was worth that expense was cutting down on their costs related to claims adjudication. In the retail sector, I think everybody knows the story of Walmart. Walmart being the masters of control, if you will, over their supply chain. So Walmart has tremendous relationships and leverage with their suppliers. And through that leverage and also a just-in-time inventory control process that they run with a lot of technology, radio frequency tracking of supplies, they can really bring to market the low cost that they pride themselves on and the low pricing. And the trade-off, of course, is that to do that, they have to be very large. They have to have a lot of leverage and negotiation strength with these suppliers, and they have to have this technology and tracking and shipping system that allows them to manage their inventory and control their supply costs the way that they do. But they have done that very, very successfully, obviously. And then the third example I have is IKEA, and I don't know how many of you live in an area where or have shopped at an IKEA, but it's a furniture store that prides itself on, again, cheap but very kind of designer-friendly furniture, especially for the younger generations. And if you've ever been to their store, you also see that one of their trade-offs is that it's really a self-serve operation. So you go there, you see what you like, you pick it up yourself, you transport it home on the roof of your car, in the trunk of your car. It comes in a unassembled fashion, and then you spend the rest of the weekend trying to put this stuff together and getting it up in your home. And IKEA, obviously, the trade-off there was that they felt that especially younger shoppers looking for this sort of kind of upscale looking furniture that they could actually purchase at a lower price would be willing to trade off this kind of self-serve and self-assembly type activity. And again, they've been very successful making that trade-off, but it didn't occur just by happenstance. They did that very deliberately and set that strategy up so that they could make that sort of trade-off and compete with other furniture stores that did not take that very unique differentiating approach. What are some examples of healthcare providers who have done things in a very unique fashion and have brought to the fore disruptive innovations? I already talked about CMS Caremark and the retail medicine approach, AmSurge and their approach to ambulatory surgery centers. But there's other healthcare systems and large healthcare providers that are out there that I think fit this bill. MD Anderson Cancer Center obviously is just world-renowned with regard to the expertise that they bring to a large number of organ system service lines within the MD Anderson organization around, again, oncology related to those organ systems. And the other thing that MD Anderson has done, because I know this because I've participated in some of the classes and coursework that they have done, is they have taken a very, very meticulous and rigorous approach to looking at their costs. And they've done activity-based cost accounting of all their major organ system service lines. I know that sounds tremendously tedious and time-consuming to all of you, but MD Anderson did that. They did that literally with a small team and Excel spreadsheets, and it took them over 3 years, but they got it done and now they can track their costs on a true cost basis, not charge-to-cost ratios, not other proxies that we tend to use for true costs in healthcare, but actually measure them through this activity-based, time-driven cost accounting mechanism that they've deployed. Kaiser Permanente, many of you know their story. They are the longest standing and perhaps most successful example out there of a healthcare provider system who is also a healthcare insurer. So they are a health plan and a provider system in one. They've been doing that, I believe, for over 50 years. And again, many others have tried that approach. Few have succeeded, but Kaiser has really done that. And it's interesting now to see that strategy is now, again, becoming more and more popular, and other organizations are trying to emulate what Kaiser has done and succeeded with for many years. So there you have it with regards to what I'm talking about and what, going back to Porter's definition, we're talking about here. So strategic thinking and strategic planning in healthcare is not just going out and trying to win the next billboard war against your competitors with regards to what star ranking you have with regards to your open heart surgery program or your bariatric surgery program. It's not trying to get the highest scores on your quality reports. And again, I don't mean to say that those activities aren't important. Obviously, quality and improvements in that sector are must-haves, but they're not really strategic. Those activities are not really going to separate you from the pack. But what's going to happen if you really want to be strategic and think strategically is you're going to have to tackle some of the major issues out there and areas of concern in a very kind of unique fashion. And let's talk about some of those issues, and even more importantly, let's talk about some of the ways that we've seen at Coker Group that organizations around the country have taken on some of these challenges. So access and patient flow. We all know that wait times in the ER, holdups in the OR, not enough beds, trouble accessing healthcare delivery, long wait times before you can get an appointment or a scheduled procedure are a major issue. And those issues are going to be even more existent as healthcare insurance expansion comes to pass through the ACA. More and more people have access to healthcare payments and are going to demand services from our organizations. So what you end up with is the challenge of, again, doing more with less, because again, the answer isn't building more beds or hiring more staff. The answer is, how do you become more efficient? One of the things that we've seen and has been carefully studied is the idea of smoothing the elective surgery schedule in order to accommodate a smoother flow and less variability of flow in patient populations through a healthcare or hospital facility. This has been shown now many times from some of the most prestigious organizations out there, Johns Hopkins, Cincinnati Children's Hospital, Mayo Clinic in Jacksonville, that if you smooth your elective surgeries, this causes a reduction in the day-to-day variability, the waves, if you will, of patients that clog up or occupy the beds in your med-surg units. And if you bring that flow in a smooth fashion by smoothing the elective surgery schedule, there's not much you can do about the non-elective visitors to the emergency department or the emergency cases that come in. But if you But if you take advantage of the fact that you do have control over your elective procedure schedule, you can really match that flow better to capacity, and again, make it flow through there more evenly, and that dramatically limits costs. It improves revenues. It, I think, most importantly, also has a dramatic effect on mortality and patient safety. So a very key strategy, I think, that more and more healthcare systems need to adopt. Effective and efficient care processes. So kind of the dirty little secret that most of you probably know, and as an older physician and somebody who's practiced medicine a long time, I can tell you is absolutely true, is that many of the care processes and procedures that we do in healthcare every day are not designed well. They are not done according to best practice, according to evidence-based studies. They're done because that's the way we've always done it, or that's the way we were taught to do it, or that's the way we find it more efficient for ourselves, the providers, not our patients, to do it. So a systematic, methodical approach to care process design is something that I think is an absolute must strategically for a hospital or healthcare system, and especially in this day of limited resources, of demands for cost cutting, and for scrutinizing all the things that we do in healthcare and making sure that it's truly value add and not waste and inefficiency, which is what we want to try to eliminate. Leveraging human resources, scarce human resources with technology. So population health management has now become the buzzword of the day. And everybody's talking about trying to achieve the triple aim. So excellence in individual patient care delivery, population health improvement, and cost reduction. And how do you do that in the most cost-efficient manner? I would contend that technology is perhaps one of the secrets to success in that regard. That especially mobile technology. I'm talking about the things that you use on your smartphones, that you use on your iPads, the things you download from the App Store. This sort of technology can be turned into mechanisms to truly provide very efficient, very effective health care. You can identify patients and engage patients through social networks. We like to say it's easier these days to find somebody on Facebook than it is in the phone book. You can deliver care remotely, electronically. Almost everybody has a smartphone, and they use them all the time. Why not use it for healthcare? And again, you can coordinate care, which is really one of the names of the game in population health management. And you can do that effectively through these communication devices, through these social networks, through this mobile technology, and do that much more cost effectively than sending out case managers, care coordinators, disease managers, whatever you want to call them, to each and every patient that you're responsible for in a population. Misalignment with providers. So again, as a physician, and as a physician who's been on both the employer side and the employee side of hospital healthcare system employment relationships, I can tell you that we've been at this now for 20, 30 years, and I'm not sure we still have it right. There's a big wave of primary care employment that happened in the 80s and 90s. A lot of those practices got divested by healthcare systems when they realized they weren't the profit centers they thought they were. And then the second big wave came along in the early 2000s, employing a lot of specialists and subspecialists, mostly to fill gaps in medical staff, but also to go out there and capture greater market share of real lucrative services such as cardiology, orthopedics, or oncology. Now we're finding that those employment relationships really haven't accomplished the kind of alignment or even more so integration of physicians with hospitals that we wished. There is a movement now called clinical integration, which tries to do that more effectively. It does it without employment relationships, although employed physicians can certainly be clinically integrated. The clinical integration is really a separate process that focuses on trying to achieve higher quality at lower cost, focuses on the value equation where value equals quality per unit of cost, and really engages physicians in that and hospitals together in that endeavor. That then allows them through some real precedent-setting cases that have trickled through the legal system to go to the market together, even though they may not be legally merged or all under a single employer ID number. These clinically integrated networks of physicians and hospitals can go to the marketplace, jointly contract, and mutually benefit from their efforts to improve quality and reduce costs. So a real, I think, important strategy that you're going to see a lot more of as we go along. The risks of moving down a strategy like I just described. So we talk to a lot of hospitals and healthcare CEOs who say, you know, we hear what you're talking about, we see all this stuff about moving from volume to value, and absolutely that's the right way to go, that's the right way for patients, that's the right way for providers, but you know, we just can't see doing that and accepting the risk that would be entailed in, for instance, contracting on an at-risk basis for population health management or for accountable care. We have seen a model where captive insurance companies are used to mitigate that risk, where providers, both hospitals, healthcare systems, and physicians are set up in provider-owned captive insurance companies. And those captive insurance companies then serve several purposes. They, number one, administer the traditional kind of TPA type functions. They do claims processing and claims data tracking. They administer income distribution for things like value-based contracting. They do things that historically have been really in the realm of insurance companies, but not in the realm of provider organizations, like actuarial projections, where they can very, very accurately predict what your spends are going to be going forward, so that hopefully when you bend that cost curve through care process design, you can realize savings, and those savings can accrue back at least partially to the providers. And last but not least, these captive insurance companies can offload a lot of the risk involved in contracting for at-risk population health management by accessing the global reinsurance market. So they can go out and reinsure an entity like a provider-owned captive, and if you have contracts for either capitated payments or value-based reimbursements, if those tend to go the wrong way for you, and you incur a lot of cost on a single patient or a segment of patients, that loss can be reinsured and protect you against serious financial harm for that. So a lot of value in the strategy of obtaining on a provider side insurance and risk management capabilities through formation of a captive entity. Poor provider performance and substandard care. So You know, I've been involved in a couple of clinically integrated networks now, accountable care organizations for lack of a better term. And I will tell you that one of the ways that we try to drive provider performance in those networks is rather antiquated. We use things like report cards, we use scoring mechanisms, and then we rely on peer review and peer accountability to try to drive performance of our colleagues. And the honest truth is that doesn't work very well. Doctors are notoriously poor at calling each other on the carpet for their clinical, behavioral, even financial performance. And so those systems of accountability that we put into these accountable care organizations, so-called accountable care organizations, really don't work very well. And what we've come up with, or we've seen out there, is the use of what we call a referral optimization system. So what happens here is that data, quality data and cost efficiency data, is accumulated down to the provider level on all the providers that are performing or operating within the clinically integrated network. That data is then used to match those providers with specific patient needs. So as a patient comes in, let's say a 42-year-old female with COPD, hypertension, and diabetes, that individual, based on their clinical conditions and demographics, are matched with the provider who the data shows is able to manage that type of patient most effectively, both across quality parameters, quality criteria, and cost efficiency criteria. And what that does is that matching process then drives performance, because if you can imagine that referrals are done by a best matched approach, and if you're a physician or other provider in that system who's dependent on that system to match you up with patients, and your number of referrals determines also your compensation, you can see that very quickly you're going to try to figure out how to improve your performance, how to get your ranking up, especially in those areas that you're interested in and that you want to see more patients in and that you're good at taking care of, and therefore it'll drive performance, and it'll do so through a more natural market mechanism and the natural referral relationships that exist in these clinically integrated networks, and not have to rely on these cumbersome and less effective systems of accountability. And then last but not least, patient dissatisfaction. So, you know, we're all subject now to scoring with things like HCAP scores and CGCAP scores, and everybody's interested in not only, you know, how effective was your healthcare services that you rendered, how efficient were they, but how satisfied was the patient? Did the patient feel that the care delivered met their expectations, and was that a positive experience for the patient to go through that? I think key to this, and the strategy that we very, very much see more than any other that's successful, is to actually engage patients in the care process design. So going back up to the second bullet on this slide and talking about setting up a care process design system, we would very, very much encourage that frontline providers do that, but also actual patients be involved in that. Because, again, we're all, yes, patients at one time or another, most of us at least, but there's nothing like bringing the perspective of a patient to the table when you're talking about the best way to deliver care. And that's really, really important, especially if you want to drive true patient satisfaction. So I hope I've in the 45 minutes or so we've been talking here, giving you an idea of what strategy is, how strategy and strategic planning in healthcare is rather unique, what are some of the unique solutions that we found to some of the key issues out there that are strategically plaguing organizations. And what I'd really like to send you off with in this conclusion slide is to think about your strategic approach, to think strategic positioning and differentiation, and not simply following the herd, buying the next Vinci Robot in town, setting up the 4th open heart surgery program, but really thinking, what am I going to do to position my healthcare system, my hospital, to succeed in this marketplace and do things somewhat or completely different. Second thing is to take a systematic approach. So again, it's one thing to have a strategy, but it's another thing to execute that strategy. And once you think strategically, you've got to start thinking tactically. Unfortunately, we tend to kind of get that backwards, and we tend to think tactically all the time and never really think strategically, but you can't really separate the two. And I would say that if you're going to achieve your strategic goals, you've got to take a very systematic, methodical approach to that. You've got to think out your tactics as carefully as you think out your strategy. Number 3 is to effectively communicate your strategy. So we see over and over and over in many hospitals and healthcare systems we go to where we talk to one department or one set of the leadership, and they don't know what the other department or the other leadership team believes is the overarching strategy. And in fact, there may not be an overarching strategy, but even if there is one, oftentimes we hear people say that that was never communicated to them, that they were never told that's what kind of the end goal is. And so effectively communicating the strategy and ensuring that you've got commitment from all of those that are going to be involved in implementing that strategy is absolutely necessary. We talked about this earlier, but healthcare is way, way, way too dynamic of an industry to not have a strategy that's flexible and adaptable. If there's anything I can guarantee you, any strategic plan you come up with, it'll be obsolete in a matter of sometimes hours or days. And so you've got to make strategy a very dynamic process. Strategic plans need to be a living, breathing document, as they say, and you really have to adapt your strategy and modify it as you go along, and unexpected challenges come up. And when those unexpected challenges do arise, we really encourage you to consider them as opportunities. Again, I talked to you about some very successful companies out there that took a look at things differently, IKEA or Progressive Insurance or even Walmart. And yes, some would say, well, the big challenge in the auto industry is how do we afford to do all this claims adjudication? And Progressive looked at that as a challenge, but a challenge that represented to them an opportunity that they could come up with a solution to that that would differentiate them from others and really make them succeed and move up in the industry. So think that way yourselves. Think about what are the challenges that everybody's facing. Is it patient flow? Is it physician relations? Is it value-based contracting and how you get there and do that without significant risk? And then take those challenges and say, what are some opportunities we have to really come up with solutions to those challenges that are going to set us apart from the pack? So I hope you've learned a little bit and that some of this is relevant to what you're doing. I'd like to take the next 10 minutes or so, if there are questions, to answer any of those. And we encourage you to let us know what's on your mind and to pose those questions, and we'll try to answer them. I'd I'd specifically like to hear from you in terms of what you see as the real strategic challenges out there, and what the kind of solutions that we're seeing that can be related to those. So I'm looking right now. I see one question coming in from Michael Jones, and he says, I wonder if the Coker Group has concrete examples of referral optimization data that can be measured, monitored, and reported over time on a provider-specific basis to evaluate provider performance and care. And the answer is, Michael, we certainly do. We work very closely. We are not legally merged or economically aligned with this company, but we work very closely with a company called Monocle Health Data Systems, and Monocle is a very, very sophisticated quality and cost efficiency database that does exactly what I just described earlier. It ranks providers according to their performance in both quality and cost efficiency metrics, and then matches those with specific patient needs, clinical conditions, and demographics. And we can certainly give you some case studies and some examples of where that referral optimization system has been deployed and the success that it's had. So thank you for that question, and certainly we'll be glad to give you as much information on that as you'd like. Anybody else have any questions that you'd like to type in? Savannah or somebody, maybe you can remind them how to do that on the system here if they've got questions about that procedure.
Yes, the question area will be in the GoToMeeting dashboard, and you can type in your question there, and we will be able to see it and answer those questions.
Anybody else have any what are some of the real, would any of you be willing to share what you think are the major strategic challenges at your organizations right now? I would really like to hear what some of the problems are that you're all up against. All right, well, it looks like maybe everybody's ready to go get a late lunch or get back to work, and I certainly understand that. But I'd like to thank everybody for their time and attention this afternoon. As we said earlier, we will be sending out this slide deck and also be sending out the accompanying white paper that goes along with it. So thank you all very much for your time and attention this afternoon. I've enjoyed talking to you, and hope to hear from you even further in the future.
Thank you, Dr. Knight. As he said, the slides will be emailed to you along with the white paper. Please participate in the poll after the conclusion of this session. We appreciate your feedback. Don't forget to check out information for our next webinar at www.cokergroup.com. We thank you very much for joining us. Have a great day.